I'm very happy to welcome you all to this webinar in Social Sciences in Antimicrobial Resistance, Research and Innovation. And this webinar is hosted by the Design OH AMR consortium, who is leading the preparation for the One Health AMR partnership, which is foreseen to start in 2025. And you will learn more about the partnership and the research and innovation objectives and how social sciences have been integrated into these objectives later on today. And I would also like to say that this is an ongoing process. So we encourage you also to take part in this open consultation that we will also provide you with a link later on that is open until next Monday. So we would really like your opinion on these objectives. And later on, we will also hear some examples on projects that have previously been funded by JPIAMR, which is the current funding joint programming initiative funding scheme. And in particular, we will also hear from Dr. Chantal Morel in University of Bern, who will speak about her research in economic issues in AMR. But first of all, I'm happy to introduce Professor Claire Chandler from London School of Hygiene and Tropical Medicine, who will speak about introduction to AMR and the role of social sciences. So please, Chantal, if you can share your screen. Oh no, Claire, sorry.
Sorry, I'm coming. Just tested it. Just... Is this showing correctly, Suzanne?
Yes, it looks
fine. There's full screen.
Yes, thank you.
Thank you. Good morning or good afternoon, wherever people are in the world. Thank you very much for inviting me to give a short summary of social science of AMR. Of course, there's a lot to say on this topic, so I won't be able to do it justice in this short time. But I would just like to flag a few of the achievements of social sciences already in AMR and some of the potential for further work and research from the social sciences on this topic. This is a really nice article by Liu et al. That shows the increase already in social science research in AMR. This is, I think, likely to be an underestimate, as there may well be other papers and books that aren't necessarily captured in this index, but it gives an idea of the trajectory. And I think since 2019, we can expect even more, which is very exciting. But what do we mean by the social sciences? I've taken this figure from a blog from 2014, which wasn't focused on AMR, but was trying to illustrate the overlaps between the social sciences and humanities as well as STEM. And I would argue that history and literary studies actually, rather than being all the way over here, when we talk about antimicrobial resistance, would actually overlap a lot more closely. There are significant and important contributions to the study of AMR that have been made by these disciplines, and particularly overlapping with social science disciplines. So key disciplines that have made these important contributions in AMR already have been sociology, psychology, anthropology, demography, political science, economics, ethics, law, history, geography, international relations, implementation science, cultural studies, communications, linguistics, literary studies, philosophy, and science studies, as well as the arts, performance and design. So although those are over here, there is this overlap, which I think is relevant when we're talking about AMR. So, and I think there is also potential for further contribution from these disciplines as well as others that are listed within here. And my understanding is that JPIAMR is inclusive in their definition of what constitutes social science. So perhaps more a reflection of the studies of the world beyond a biomedical set of disciplines. And my experience has been of a very welcoming attitude from those who work in AMR from STEM disciplines, sciences, technology, engineering, and mathematics, based on the recognition that this is a problem that extends far beyond the walls of cells or laboratories or consulting rooms. So what do we share in common across these disciplines, social sciences and humanities? Our understanding of the phenomenon of drug resistance is expanding and is increasingly understood with a wide lens perspective that covers multiple disciplines and sectors. This demonstrates both the limitations of our existing categories of disciplines and sectors for understanding a phenomenon like this, which we have in common with things like climate change, and also demonstrates the willingness of those working on the issue already to expand beyond traditional silos. Antimicrobial resistance is increasingly understood as a biosocial issue, one that exists across the boundaries constructed in research and practice. As such, the societal dimensions of antimicrobial resistance are brought into the foreground. And commonly, this revolves around human behaviours such as hand washing or prescribing, but it does extend to wider social questions around collective responsibilities, societal values and norms, economic and political imperatives. The social sciences are able to elucidate the ways in which these dimensions intersect with drug resistance emergence and its management. So therefore, there are a range of social sciences that are able to inform our understanding of the problem and the path forward for antimicrobial resistance. And each discipline has different expertise to bring to this. And furthermore, it's important to note that social sciences are positioned to respond to AMR as a problem that manifests in different ways in different places and differently over time, rather than seeing it as a universal phenomenon. This can not only shed light on the parameters that are predominantly social, but can also contribute to an understanding of the biosocial dynamics of antimicrobial resistance. I want to flag a few of the social science contributions already made to AMR, and this is by no means a full list, it's just a few highlights, and already is an extensive body of work. The research led by economists that proposed a macroeconomic model of AMR had a huge impact that propelled the challenge into the spotlight in a new way, particularly when this work informed the O'Neill report commissioned by the UK government and then CMO Dame Sally Davies and led by Lord Jim O'Neill. Many economists, historians, geographers, anthropologists have also shown the places where antibiotics are, their distribution, supply chains, value chains, and have unfolded the ways in which these distributions are often uneven and unequal across geographies, genders, age groups, urban and rural areas, etc. And without this, we wouldn't now know how to measure and count antibiotics in surveillance in the way that we do. Similarly, looking at the multidisciplinary work of social scientists working with epidemiologists and microbiologists, they have shown the ways that AMR is unevenly distributed and been able to explain these geographies without, for example, being able to ask the questions about where the burden of AMR might be higher because of social and historical legacies, for example, in informal settlements. This is critical not only for highlighting hotspots, but for recognizing the points at which intervention is most usefully to be applied, rather than making assumptions about how people might live and the resources, motivations, and expectations that they are subjected to. Those from the humanities and design fields, together with sociologists and those interested in bugs, have mapped antibiotic resistance routes in places like hospitals, created innovative ways to design solutions to improving infection control, looking at multiple pathways and movements of people, bugs, trolleys, lifts, and so on. This is fascinating work on the built environment, which includes being informed by, for example, performance studies. So this goes beyond what people might imagine the role of social sciences and more as broadly defined. Looking at the social relations between professional groups, such as in hospitals, social science has been essential to the establishment and effective functioning of multidisciplinary teams, which have deep-seated hierarchical structures to push against. an enormous body of work on this has emerged from across different country contexts, predominantly led by social scientists. And this also extends and can do more to the cross-sectoral functioning required within a One Health imperative to address this problem, which requires crossing silos, funding streams, and multiple social domains for intersectoral working. Multiple economic solutions have been crafted through careful economic analysis and the deployment of economic models, for example, to address the issues of antibiotics in food production, to look at the pipeline of antibiotic production, and through to incentives that can be used to improve prescribing within models such as insurance schemes. Behavioural scientists have had a role to play in providing ideas of nudges to improve prescribing through analyses of the ways that different practices are shaped by reluctance to deviate from norms and so on. And these have been useful in looking at ways to nudge, for example, farm workers to wash their boots in disinfectant before attending farms, or making certain routes for prescribing more easy or difficult. Social scientists have been able to support improved designs of surveys relating to antimicrobial resistance, including for antibiotics, that enable more accurate data collection and interpretation of findings. And as well as these more individual approaches, social science has been effective at showing how we are currently framing the problem of AMR and providing alternatives. For example, switching away from antibiotic misuse in recognition of the pejorative implications of the term, and shifting understanding of antibiotic use away from individual decisions towards the structural reasons and political choices that have meant particular practices have become inevitable, such as antibiotics used as a quick fix for hygiene or as a substitute for more holistic care. At another register again, social scientists, such as those in the legal profession and the international relations scholars, as well as political scientists, have been active in studying the nature of the AMR challenge as an international one and the relative burdens and responsibilities of different nations in finding paths for agreement on coordinated responses, and the potential for a pandemic treaty that includes AMR is a credit to those scholars working in that field. So this is just a brief summary of some of the work that has already been done by social sciences, which I think demonstrates that they have already made an important impact in the field of antimicrobial resistance. What's the potential, though, for social science in antimicrobial resistance? Oh, I was going to tell you about anthropological studies because I'm an anthropologist. Anthropological research has tended to be the most focused on the end user of antibiotics or individual practices such as hygiene practices. And this has resulted, together with the work of other social sciences, in a large body of empirical work around practices. And this has been very important in shaping stewardship campaigns and previously in rational drug use campaigns. More recently, anthropologists, together with other social scientists, have taken on different theoretical framings to look at how AMR and antibiotic use are the product of wider social forces. And this has resulted in a growing body of literature describing the entangled roles of microbes and antibiotics with not only health and care, but many of the social, economic, and political dimensions of life around the world. And whilst there have been trials of interventions based on attempts to change individual practices of health workers, farmers, or community members, there have been fewer intervention studies to look at the potential impacts, intended and unintended, of changes to systems or societal parameters. The evidence base for such interventions now needs to be built and to be co-created by social scientists with those who work in the systems and structures that currently are entangled with bacteria and antibiotics. So what's the potential for social science? Well, I think there's a huge number of unanswered questions. You can see here in this nice article of the State of Social Science Research on Antimicrobial Resistance, AMR is in, social science on AMR is in green compared with social science on other topics. And so we're still relatively a small group. And I really think that will need to change given the status of AMR as one of the most critical problems facing us as humanity at this time, and our critical reliance on these drugs to live in the ways that we do. One of the things I think we need is a platform to find social research on antimicrobial resistance and the implications of this social research. We need syntheses of social research on AMR, And we need further intersections between disciplines within social science and with STEM. And we need the recognition that antimicrobial resistance is as much a social as a biological phenomenon. And social science is not only therefore there to ensure the uptake of biomedical solutions. Some potential questions for antimicrobial resistance from a social science perspective, something that I think we need to be looking at more is what is the current and predicted societal burden of AMR? How is this distributed and explained? What size of impact might societal interventions such as sick pay, healthcare payment structures, formalisation of housing, food regulations, and so on have on the emergence, transmission, and burden of antimicrobial resistance? What sorts of transnational interventions, trade agreements, development targets, supply chain technologies might impact emergence, transmission, and burden of AMR? How can the implementation of action on AMR be integrated with other national agendas, for example, maternal child health, STIs, agricultural development, tourism, so that investment could result in co-benefit? What insights can social sciences offer to improving prevention and control of infections where traditional WASH and IPC efforts have failed? What can a more than human approach offer to approaches to manage or live with drug-resistant microbes? And as a schematic, this is where I think we currently have much more of the evidence base about the impact on what we can do to impact antimicrobial resistance. But I do think that given the observational studies that show that there are things that at the structural level that could potentially have an impact on AMR, we really need to be growing this evidence base, even though the political ease of implementation may appear to be small. And that's where I will leave it. Thank you very much.
Thank you very much, Claire. So I think that we will, there are some questions in the chat, but I think we will save them for the question and answer session later on. So I would now like to give the word to Laura Marin, who is the coordinator of Design OH AMR and also the head of the JPIAMR Secretariat at the Swedish Research Council. Please, Laura.
Thank you, Susanne. Hello, welcome everyone, and good morning, good afternoon to all of you. I'm very happy to see that there are so many of you joining today in this webinar. We are really happy to create this, to see this interest of the social science and humanities community into the AMR field. And I'm just going to give you a very brief words about AMR, what we've been doing the last years regarding supporting research on AMR, bridging the gap, and also what are our future plans to the development of a new joint research program, and what could be the role of the social science and humanities disciplines in such a program. Just to give very few words about antimicrobial resistance, that is the topic of why we are here today. Unfortunately, antimicrobial resistance is increasing year by year, so drug resistance is really on a really exponential degree at the moment, and is considered one of the major threats to global health. As Claire just mentioned, the burden is very heavily, and is, for example, is combined of malaria, TB, breast cancer. All this burden combined is less than the current burden of antimicrobial resistance. So it's really an issue that we need to look like, we need to develop and dedicate more resources, and we really need the views and the contributions of the social community to really how we can tackle this societal challenge. Also, just to say, in the last years, it has been a more and more political attention on the area of AMR. We saw since 2015, when the World Health Organization published the first global action plan on AMR, how at the moment most countries of the world has developed national plans to tackle AMR, including the European, of course, the European Union. And in this framework and in the yearly resolutions of the G7, G20 regarding how can we tackle internationally AMR, it has been really increasing in the political agenda internationally. Therefore, in the last years, the Joint Initiative on Antimicrobial Resistance, JPIAMR, which is an intergovernmental initiative, has brought together at the moment 29 countries around the world, and many other countries that are partnering in the funding schemes that we are dedicating. And this platform and this brings together mainly the Ministries of Research and the Ministries of Health on how to coordinate the research programs dedicated to AMR nationally and internationally. So what can we support together? What are the critical and the key research priorities that we should be funding and supporting at the international level? And what are those that we should be doing at national level? So it's about all this alignment and coordination and basically supporting research. In the last years, we have been mobilized at the international level about 140 million euros to support research on antimicrobial resistance, really in a holistic approach. If we look at the national investments on AMR, who was not significant like 10 years ago, we are very happy to see that, especially in the last 5 years, has been increasing at national level. Still, as Claire was looking at these statistics on how many contributions are from different disciplines in different topics. For example, we know the funding dedicated to cancer research is like 3 times or 5 times more than in antimicrobial resistance, even though antibiotics are basic use for cancer treatments, and the increase of resistance in those treatments is really endangering the cancer patients. So it's about also like this important contribution to social science, how we can convey this message and how we can mobilize the different political spheres to dedicate more attention and more funding in the AMR field, and how we can bridge this gap. So the different projects that we've been funding has been really at international level. We have been supporting researchers in 77 countries worldwide. We have specific schemes to support researchers in lower income countries, providing new perspective and really where the burden on those countries where the burden is at its greatest volume. And also been trying to work moving from the biomedical field and really having a more One Health approach into how to tackle AMR. In this sense, in the last years, we've been funding projects from the transmission area, from therapeutics area, from diagnostics, but also now we are in discussions on how can we build a larger joint research program internationally, and how we can really increase the level of ambition and support further. In this sense, we are at the moment preparing for a joint research program. It is going to be called the Future One Health AMR Partnership together with the European Commission. And in this sense, the aim is really to tackle AMR and how we can put research at the center to reduce the burden on AMR. In this sense, it's about really addressing the current knowledge gaps and bridging between the silos of AMR, so from the human health, animal health, and the environment. How can we work together in these different areas, and also how we can include socioeconomic aspects at the center more of these interactions, and how this affects human health. It's very much, this partnership will be about addressing the European Union One Health Action Plan against AMR at the core by boosting research, development, and innovation. So it's going to be a research program that is going to be looking forward to foster the generation of novel solutions to prevent and treat drug-resistant infections, as well as improve surveillance, diagnostics, and control of the spread and the transmission of resistance, and not only support basic research and the discovery stages, but also to test and validate such solutions and facilitate its uptake. The general aim is really to reduce the burden of AMR. The major mechanism of how we are going to do that in this research program is really through competitive calls and activities to support the research community. The partnership will cover different objectives, but for the sake of today's webinar and discussion, we're going to focus on those elements that are about boosting research and innovation. In this sense, we will develop mechanisms to support research but also to support capacity building and increase the community of AMR, the scientific community of AMR, by developing also capacity programs, networking programs, training, mobility, and also finding ways to facilitate data sharing. And is in those programs that will benefit the scientific community that we are looking for your input. How we've been working in JPIAMR the last years has been to develop a joint research and innovation agenda, who was the very first one developed in 2014. And this has got several updates. And together with this agenda, it has come a roadmap of actions who plans what are we funding and supporting every year. So we have calls every year. For example, next Monday, we're going to launch our new call for 2023. So if you're interested, you can check on Monday the announcement of the call that is going to be in the area of diagnostics and surveillance. But this plan and this agenda, if we have, it runs until 2024. And therefore, we are preparing to launch this new partnership in 2025. And the process of preparation is about developing this research agenda, who has different elements on it. And the most important that we really need to input from the scientific community is the definition of these One Health research and innovation objectives, as well as the roadmap of actions of which funding mechanisms, with areas we are going to be funding and supporting, which type of tools, which are these research questions that we should be addressing to really make a difference in still making efficient and effective the current antimicrobials that we have and the therapies that we have at the moment, and how to develop new ones. And all this preparation will lead to the launch in 2025 of the partnership and the first calls in the framework of such a program. And I will leave the word now to our colleague, Sophie, who is going to tell you more in details about these research objectives. Thank you.
Thank you very much, Laura. So then I give the word to Sophie Gay at the French National Agency, Research Agency, which is also part of the design OH AMR. Please, Sophie.
Thank you, Susan. Can you put on my camera, because I cannot have I don't have the access.
Sorry for that.
Okay, so you should be able to see me. Yeah, thank you, Susan. Thank you, Laura. So indeed, I will present today the research and innovation objectives of the future partnership. Okay, do you see my presentation in presentation mode, in full screen?
Yes.
Okay, perfect. Thank you. So I will start exactly where Laura stopped. As Laura mentioned before, so we are expecting to launch a partnership on One Health AMR in 2025. And so in order to be ready to launch a partnership in 2025, so we need to prepare some works and so to do some groundworks. And this is where we are now. So in 2022 and 2023, we are preparing the launch of the partnership, especially preparing some documents, strategic documents needed for the submission of the proposal. In particular, among those documents, we are preparing the strategic research and innovation agenda. So what is this strategic research and innovation agenda? It's a complex document. I will not enter into detail today. We have description of impact, portfolio of activities, or monitoring framework. But most of all, one important part of the strategic research and innovation agenda is that it will contain the priority research areas and the research and innovation objectives of the candidate partnership. So of course, so as Laura mentioned you before, so we have already some documents, pre-existing documents existing from JPIAMR. And so those documents that are published on the JPIAMR website contains already a description of priority research areas and priority research and innovation objectives. But those documents are a little bit older in a way. So now we have to update them. And in addition, we have to go beyond those documents, because as Laura was mentioning, the partnership will learn the pre-existing JPIAMR, but it's expected to go beyond, in particular in terms of topics and in terms of impact. And so this is where social science is expected to play a role. So we are expecting to have more transdisciplinary projects and to increase the role of social science. So what will be designed by the research project will be really implemented in the real life. So what does it mean, research and innovation objectives? So research and innovation objectives mean that it will define the scientific research perimeter of the partnership. Here, it's very important to underline that our partnership is a research partnership. So of course, we have other actions that might be needed to control AMR, but it will be really out of our scope. What is in our scope is really a research, scientific research partnership. So the research and innovation objective will define the research questions that should be tackled by the funded research project. So it's not really how you want to do good science to tackle AMR, but it's more what you need to do to tackle AMR. So it will answer to the question what. So on the left side of your screen, you have already a capture of the first document that have been published in December. It's the first draft of the research and innovation objective of the One Health AMR partnership. So the research and innovation objectives have been regrouped into 5 thematic areas. So diagnostics, surveillance, transmission and evolution, therapeutics, and intervention. And so we have the different research and innovation objectives for the partnership that are regrouped inside these 5 pillars. But in addition, we have cross-cutting issues. What does it mean, cross-cutting issues? It means that it's issues that should be addressed in each of the pillars. And inside this, for those cross-cutting issues, we have in particular social science and implementation science. And so we decided to create a working group on social science in addition to help us and to support us to increase the weight of social science in the future partnership. So what was the aim of this social science working group? It was to define the research and innovation priorities in social science, also to ensure that the co-implementation process will guarantee a good participation and evaluation of social science, and to mobilize experts outside of this group in social science disciplines that would be interesting in AMR. And so, for example, here you have a list of issues that where social science is needed. So I will not detail into detail because already Claire touched those aspects. So, for example, we need to identify the needs of the local population. We need to propose solutions to guarantee the access of local population to appropriate antimicrobials. We need to evaluate different communication strategies aiming to avoid antimicrobial misuse. We need to identify socioeconomic factors encouraging antimicrobial misuse. We need to develop new economics model to guarantee the development of new antimicrobials. We need to define a proper ethical balance between the environmental cost of some antimicrobials and their capacity to save life, and to define a proper ethical framework that could reduce the time for a new antimicrobial to arrive to the bench of the patient. And this echoes, of course, what we have seen for COVID, for example, and all the debates in the society for COVID. So coming back again on this first draft, so as I told you, it's a cross-cutting issue. So social science have been really integrating inside the 5 pillars. Anyway, to show that we really consider social science, at the end of the document, you have some tables in which we extract some priorities in social science to show that it was really taken into account in the design of this research and innovation objectives. So for example, you have a list here for therapeutics, for example. What we consider would be, for example, to maximize the probability of a new drug entering into the clinic, but taking into account an ethical framework, and so on. So you have different priorities. I will not enter into detail, and I strongly encourage you to read these documents if you are interested. So now how we can see social science, we can see them in the partnership in 2 angles. So the first one is, of course, we want social science to complement projects in biomedical science in a way that what will be discovered in a biomedical, for example, new diagnostic tool, it will not stay at the bench of the researchers, but it will be really implemented in the future. So it will be a kind of added value for the project that will allow us to really create impact and go beyond the discovery at the bench. But also we expect social scientists to lead projects. And this is also something that it's very important for us. So for example, project in economics or in ethics, it has to be led by experts in social science. So we have the two ways, and it will be important to keep those two ways together. So just a few words on the timeline. So as I described you before, so in 2022, we already started a good part of the preparation for this partnership. So we organized a lot of consultation during the first semesters 2022 that allow us to grab feedback from the research community and relevant stakeholders on the research and innovation objectives in AMR. Then we took some time to draft a first document that was published in December 2022. And now, and I will come back later on this, we will open a consultation and we will finalize the research and innovation objectives in January, February 2023. Just to let you know that, of course, we are not doing this exercise in isolation, but WHO also organized some consultation and will also publish some documents on the research and innovation priorities. And so we are working with them in order that our partnership will also serve the WHO priorities. So as I told you, we published this document in December 2022, but it's not the final document. It's the first draft, and you are encouraged to give your feedback on this document using a survey that is open until next week, so January 16, a short time is remaining. So we encourage your participation, and also if you can share this with your colleagues so we can have a huge feedback on this first draft. So it's not a complicated survey, it's an easy survey. You can choose the topic on which you wish to give feedback. So you are not obliged to give comments on different areas in which you are not familiar to. You can choose, for example, to give only on therapeutics, feedback on therapeutics or transmission, but you can also choose to give feedback only on cross-cutting issues such as social science or implementation science. So it's really up to you. You can just pick the subject of your interest. Just to give you what will be the next steps. So as I told you before, we expect the partnership to be launched in 2025 for a duration of 7 years, so up to 2031. So in which we will launch calls. But now the next step. So of course, we need to prepare the calls. And so we will start in March and May of this year, a work in which we will take the research and innovation objectives and we will try to turn them to define topics of the call and activities to be carried out during the duration of the partnership. So that's all for me, and thank you for your attention, and I will be happy to take questions during the questions session later on. Thank you.
Thank you very much, Sophie. So now we will turn a little bit to the past and see what projects with strong social science integration that has been funded before by JPIAMR, and it's my pleasure to introduce Dr. Chantal Morel from the University of Bern, who is actually also the lead of at least one of the previous JPIAMR projects. And she will talk about economic issues in AMR. Please, Chantal.
Great. Thank you, Suzanne. Do you see my presentation in presentation mode?
Oh, not in presentation mode. Now we see.
Okay, sorry.
Now.
Okay, perfect. Okay, thanks. So I'm Chantal Morel. I am a health economist, and I'm just going to be very briefly going through a couple of projects that I did, or actually one of them still ongoing, under JPIAMR. So these are sort of economics-focused studies that one might think are a bit oddly placed, given the calls that were put out. But I just wanted to give an example of how actually, these economic focused projects actually fit quite well within the calls. So the first one I'd like to present was it was for a call that was put out in 2017 that looked at comparing prevention, control, and intervention strategies for AMR infections through multidisciplinary studies, including One Health approaches. Now, the coloring, the blue coloring here, so the emphasis on strategies is my own. Me and my team basically wanted to see what we could do in this case to come up with strategies or a strategy to try to get different stakeholders on the same level with regard to AMR. So all moving in the direction of trying to combat AMR. So in this case, trying to bring industry on board with us. So rather than having industry incentivized towards maximizing the use of antibiotics, to actually have them be incentivized towards protecting the efficacy of their antibiotics. And so this is what we did. It's a project called the Antibiotic Susceptibility Bonus. And it involved a few different teams, one from Canada, Sweden, and Switzerland. And what it's about is trying to offer a bonus to companies who produce new antibiotics that remain effective over time. So essentially, seeing how resistance grows to their antibiotics every perhaps 5 years, and providing a bonus if resistance remains below a given level. And the idea of this is to try to offset some of what are potentially, I'm careful not to say overuse, but perhaps less clinically justified use of their products. So rather than pushing the sales of their products, they could also be trying to market them in a way that that reinforces good stewardship. Now, we had to come up with a way to see how the bonus would be weighted, so how much they would earn from the bonus. And we decided it would be based on susceptibility, utility of the product, and access that is granted to the product. Now, at the moment, routine surveillance of resistance to antibiotics does not actually include, at least across Europe and actually nowhere in the world, does it include the newest antibiotics. We are at the moment on a routine basis only looking at growth of resistance to the older antibiotics. So if we were to include the newer antibiotics within routine surveillance, how would this look? So this is one of the first things that we had to explore. I won't get into too much of the detail about that, but our conclusions were for this project. So in order for surveillance to be able to support this bonus scheme, well, a few different things. So we would not rely necessarily on automation. That was one assumption that we went into in the beginning, that we totally do not need automation for, to get good susceptibility estimates. Also, we would probably be choosing 3 to 4 pre-established priority pathogens. And then finally, we would not probably be able to use susceptibility that was established using MIC breakpoints. The reason for this is that we don't want companies, so MIC breakpoints can change. They can be changed, for example, by UCAST. But we don't want companies putting pressure on UCAST to change those breakpoints in order to qualify for a bonus. So instead, we decided we would go with with wild type. So if basically there would be, if we're just looking at the change in wild type, we wouldn't be creating that perverse incentives to try to change breakpoints. Effectively, it's a much more objective assessment of susceptibility. So we would be looking at a sort of a binary assessment of whether or not resistance was at an acceptable level for a new product, it would get either a weight of 1 if it were 100%, or if it were less than equal to 50%, it would be 0. So sorry, this is not binary. And for utility weights, we obviously cannot be looking at unit sales to determine whether or not a product is useful, because that would just incentivize pushing of sales, and we don't want that. So we need to be not basing utility on number of units sold, but rather we would have to have some sort of justified use assessment. So whether or not the use that takes place is justified. Access, we would have to have, so sorry, this would be binary. Is the company making their product available where there is clinical need for it? Now, there's no way you could be really asking companies to, well, you shouldn't be asking companies directly to tell you whether or not they're fulfilling this criterion. So we would have to have some sort of what we call the passive supply chain. So looking at basically speaking with payers to find out whether or not they had made a request for a product that was not fulfilled or fulfilled. So that's the first project. Again, that was called the antibiotic susceptibility bonus. We have a few papers out on it if anybody's interested. The next project, this was funded, so just in 2021. Well, it was from a call last year in 2021. So it's ongoing now. This, the call that it related to was One Health interventions to prevent or reduce the development and transmission of antimicrobial resistance. So again, the emphasis, the blue letters, they're mine. But here we were trying to come up with interventions that could help promote, basically increase the momentum with regard to national action plan implementation in countries. Now, let me just skip these. So the sort of pretext here is that most countries have had a few years now where they've had a national action plan agreed within country and so, effectively in place, but they have not made any progress in terms of implementing these plans. Now, it seems that this is for two reasons. One is an incomplete perception of the losses associated with antimicrobial resistance. So basically effectively the economic burden, economic/clinical burden. I do include clinical within the overall economic burden, but and then also insufficient funding to implement the national action plans. So basically, this is what's going on. We have somewhat of a vicious cycle. There's insufficient prioritization of AMR at national level, which then means that when there are funding opportunities that could be AMR related, those countries are bypassed because there's been no sort of official expression that AMR is a priority within that country. So they're just bypassed for these funding sources. And then because they don't have the funding, then they can't really explore the impact of AMR. And so then it leads to, again, insufficient prioritization of AMR within country. So you end up with this vicious circle. So our goal with this project is to try to break that circle by trying to estimate what the full economic cost of AMR is within a couple of countries. Our two countries are Zambia and Malawi. And our group is made up of a team from Lusaka, a team from Bonn, Bologna, Antwerp, Dublin, and Blantyre. And we have, people from all different disciplines involved. Of course, we're working with, many partners on the ground. So it's far beyond just the experts involved with the project. An important part of this is going to be working with the stakeholders who need to be involved in NAP implementation on the ground. So this is how it works. This is a really bad slide. I just haven't gotten around to improving it yet. So we have what's called the GAP1 framework that establishes basically the cost elements that we need in order to do this study. This was established by the GAP1 network, which is actually also a JPIAMR funded project, or it's a network that created this costing a couple of years ago. And in some ways, it's a bit of a wish list because no country is going to have all the data necessary, but at least it lays out ideally what we would have to do a proper costing. So this is going to provide the economic picture for what AMR is costing in Malawi and Zambia, which should help advance the negotiations with donors. We're also going to be working with the countries on these proposals. So for example, to World Bank or USAID, et cetera, try to get the funding for implementation. And of course, it's going to be bringing together within country the various ministries and other stakeholders to try to improve basically the understanding of AMR and its impact on all sectors. Now, a key point here is that the call here was about interventions. Now, we actually are trying to see whether this costing process can be an effective intervention in itself. So can you use a costing exercise to bring together all the different stakeholders you need in country to then help build the momentum for national action plan implementation? So in some ways, this is really the link to the call. It's an intervention in and of itself. In some ways, it's a bit of sort of it's an implementation study or an operational study in this regard. And so this is really our goal, trying to bring together here all the groups to improve the speed at which national action plans can be implemented. So just as a conclusion, there is ample opportunity for social science projects within JPIAMR funded calls, including ones that are focused on economics issues. It's about finding the way to fit them in. But yes, it is extremely flexible. At least in my experience, it's been very flexible in how they interpret, basically what they're asking for with regard to these AMR related projects. And if you are health economist or a social scientist of any sort, don't hesitate because really there is a lot of flexibility in what they accept. Thank you.
Thank you very much, Chantal, for an interesting talk. So I would just like to, okay, can you please exit yours or stop sharing?
Yeah, of course.
Sorry. So do you see in presentation mode now? Yes, thank you. So I would just like to mention a few other JPIAMR funded projects, and I would like to say that this is not a complete list, of course, it's just a couple of examples, so don't feel that I have left someone out if you are missing some projects that you are yourself processing. So I think one field where social sciences have a very important role is intervention, because of course, including behavior, of course, but also to the implementation of different interventions. And there, as we have heard, I think it's also important to take into account social science already in the planning of the interventions, so that there will not be any problem that the barriers are taken into account already at the start of the project, so we don't end up with solutions that will never be taken up. And one project that I would like to highlight is AMR Resilience, who developed an interdisciplinary social ecological framework to identify success and failure factors for intervention. for cost effectiveness perspective, for example. Another example is the Cabo Eco project that is still ongoing, where they study behavioral interventions in Burkina Faso and Congo to improve hygiene and to educate pharmacy staff in order to reduce antimicrobial use. Another area is surveillance, and for example, we have the NewVis project or network, where they identify local networks of hospital, primary care centers, and patients, and how AMR spreads in these networks, including then social networks as well. And for economy, Chantal already mentioned the GAP1 projects, where they did a comprehensive analysis of the direct and indirect economical burden of AMR in a One Health perspective. But it can also be, social sciences can also be integrated in, for example, diagnostics, for example, the AMR RDT projects, who identified barriers to the development, implementation, and use of rapid diagnostics, including behavioral change and business model. And another area is, of course, antimicrobial stewardship, and there are some projects that have, or networks that have identified the research priorities of such antibiotic stewardship programs, and also for the uptake and knowledge transfer. But again, this should also be taken into account already in the planning of the projects. So these were just some examples of how we can integrate social sciences into the AMR projects.